Hello, everyone. We'll be starting in just a couple minutes. We're just setting up um, the cart transcription. Okay, can we test the captions? All right, let's test. Okay, great. We can get started now. Greg, I'm turning it over to you.
Hi, so welcome and welcome, hello and welcome to our discussion today on racial disparities in public health. People with disabilities have been at the front line of any number of public health issues for years, and people who also experience racial marginalization are at an intersection, at the intersection of race and disability, even more so. A lot of our discussions around public health are predominated by discussion of the events of the past year of COVID-19, the pandemic, but those of us who have lived this know that these issues have existed for much longer. Today we'll be discussing the sorts of barriers that exist for people of color in getting and staying healthy and getting the healthcare that they need, and with a particular focus on disabled people of color and the experiences that they have. We'll also be talking about COVID-19 and sort of how that experience has impacted communities of color, and we'll talk about how what we can do to sort of address some of these problems. So with that being said, I would like to go around and introduce our panelists. I'll start with myself. My name is Greg Robinson. I'm a policy analyst with the Autistic Self-Advocacy Network. My pronouns are he and him. I came to the Autistic Self-Advocacy Network from a background in public health, and that's what brings me here today. So I'll turn it over to Hector, if you would like to start.
Thank you, Greg. Hello, everybody. Buenas tardes. My name is Hector Ramirez. My pronouns are they, them. I am Chiricahua Apache and Mexican. I am a disability rights advocate. I'm a person with disability. I'm autistic. I'm hard of hearing, and I have a psychiatric disability. And I want to give first, before I start, a visual description of my background. I'm using a Zoom background for my National Disability Rights Network agency that I'm a member. I am a 45-year-old beautiful autistic person, very handsome, if anybody's asking. I have sleek long hair, and I have a black shirt that has a logo on it with a Native American woman looking up, and it says Rise. And it's part of our national awareness campaign from Illuminative. And I have a beaded necklace that was gifted to me by a Seminole friend of mine. And I am coming to all from you from the unceded territory lands of the San Gabriel's, San Bernardino, Tongva tribe, who are the ancestral people of the lands of what many people call Los Angeles, California. Happy to be with all of you, very honored. I'm on the Board of Disability Rights National in Washington, D.C. and Disability Rights California. My background is both an activist in civil rights. I have a science background, and I'm a long-term activist. I was institutionalized as a child. I'm pre-ADA generation. And I am one of those disability people that just really believes that a lot of the work that we do really has to do around systemic advocacy for a lot of communities. And I'm very privileged and honored, I want to say, to be asked to be part of this panel and with all of my great colleagues. So thank you very much. And I'll popcorn it. Can I popcorn it? Yeah, let's popcorn it. Can I popcorn it too? Let's see, Ryan. Ryan, can I popcorn it to you?
Thank you, Hector. Hi, everyone. My name is Ryan Easterly. My pronouns are he and him. I serve as executive director of the WITH Foundation, which is a private foundation that promotes comprehensive healthcare for adults with developmental disabilities in the United States. I am a Black man with Black hair, Black glasses, wearing a teal shirt with a Black jacket on, and I am sitting in front of a white wall with some diplomas on it. I am an individual with physical and non-apparent disabilities. And I believe that ultimately, if people with disabilities, especially people of color with disabilities, can appropriately access healthcare, that it enables us to live fully fulfilled lives. So if we can really address healthcare, it enables us to go on and do the many other things, such as changing policy and in the arts and many other things. So that's what brings me here today. And I'm gonna popcorn it to our next presenter.
Hi, my name is Shivani, and I'm really glad to be here. My pronouns are they, them. I am a South Asian disabled and queer activist and artist from New Delhi, India. So that's where I live in India. I am part of a collective called Determined Art Movement as an artist. So my art practice involves journaling, creating zines, poetry, painting on big and unique surfaces. And I like to use the various forms of art for justice, collective organizing, live documentation of political narratives and radical thoughts. I also work as an interdependent consultant, researcher, writer, advisor, and facilitator with an emphasis on advocacy for disability, sexuality, gender, policy, and accessibility. I guess the reason why I'm here is because I have led and facilitated a lot of workshops on SRHR, which is sexual and reproductive health rights, on pleasure, the medical industrial complex, disability justice, bodily autonomy for people with disabilities, and policy with the intersection of mental health, and I work very closely with the UNCRPD, especially around especially for youth with disabilities from around the world. Um, and my visual descriptions, I am a brown skin femme with curly hair. I'm wearing a pink multicolored headband and glasses and some jewelry. Behind me is some of my mural artwork and some other artwork from trans and queer artists. Yeah, I hope I covered everything. Thank you.
Thank you to all of our panelists for joining us today. It's really a gift to have your expertise here to join us in this discussion. So I'll jump right into it. This is a big question, but as we were discussing, there are many barriers that exist for people of color in getting their health needs met and receiving adequate health care. So we want to ask what sorts of barriers exist, but we want to narrow it down a bit and sort of as a follow-up, what are some crucial aspects of healthcare access that you think people don't necessarily think of or consider as important as they are, such as things such as cultural proficiency or literacy. I'm gonna go in the same order, unless there's an objection. But so Hector, if you want to kick it off, we can start with you.
Thank you, Greg. As people of color, we know on a daily basis that the challenges that we experience not only as people of color, but as people with disabilities, is the systemic racism, the stigma, the discrimination that is oftentimes really built into a lot of the healthcare settings or benefit settings that exist not only in local municipalities like we have here in the United States, but actually all throughout many other countries. The lack of actual authentic representation and definitely the absence of having people with disabilities that represent especially communities of color or those communities that are hardly marginalized has been a continual factor that has delayed and acted as a significant barrier for people with disabilities, especially during this pandemic, from accessing services, particularly those services that we need to be able to survive, stay healthy, protect our families, and protect our communities. And I think it has been an obvious eye-opening to the rest of society because it was very obvious to many of us already the significant inequities that are part of Western models of care that haven't really kept up both to the needs and modalities of the people that they're supposed to be serving. And so that has been perhaps one of the main contributing factors why people with disabilities in the United States and across the country not only have had the worst health outcomes, but have had the deadliest ones. People with disabilities during this COVID pandemic have had to bear front the consequences of inaction, misinformation, and inequities with our lives. Our family members, our friends, some of us have contracted it or been severely impacted by COVID. And it has been all with the nuisance that, this virus was only going to impact a certain amount of people or certain people without these individuals really highlighting the fact that the ones that were being forced to bear the brunt of these inequities were us. And so I think that has been perhaps one of the most sobering and horrifying things to witness on a global scale. But I think that also gives us an opportunity to really garner some momentum and try to have some systemic change. not necessarily to make the system better, but so that we can survive this pandemic, which is not at all over, especially for people with disabilities.
And I would build on that to just acknowledge that, as I think all of us as panelists know, and all of us here know, that communities of color still struggle with basic access to diagnosis. And oftentimes diagnosis is the first step to getting the services that you need, including it as part of your identity if you choose to. But many communities of color and many individuals of color still struggle with even achieving a diagnosis. And also there is still a lack of, when you're looking at healthcare services, of acknowledgement of that we are all bearers of intersectional identities. And I, as a Black man who's also identifies as a gay man, even when I go to the doctor, I end up having to segment different forms of my identity based on what my needs are or what most needs to be addressed in this particular session. And I feel this is the experience of many people of color. So how do we move to really acknowledging and being intentional in addressing the intersectional identities we all have? Also, especially in the pandemic, there have been more discussions around telehealth. And with Foundation's history, we've been an early funder of telehealth services, but we're also very aware that, especially in communities of color, this is a complex issue because you're dealing with access to technology. You're still dealing with, can you receive culturally competent care in telehealth settings? So are we addressing the complexities around telehealth? Also, Greg encouraged us to talk about cultural proficiency and health literacy and accessibility. Those are all issues that are in the forefront, but I would also raise up just being intentional around the fact that there are many AAC users that are people of color, that it's important that healthcare institutions and healthcare settings be intentional in addressing the needs of AAC users. And when I say AAC users, I'm referring to those that use augmentative and alternative communication. So that's what I would add.
And Shivani?
So here I will start with like speaking from my own experiences, but I know that it is the experience of a lot of CRIP and queer peers and friends that I have. They've gone through very similar things. So for me personally, the so-called medical professionals and doctors don't understand my body, and they assume a lot based on how they see me. I think in South Asian culture, often they will, ask very irrelevant things like why are you not married, or your educational background or your family background, as if it's some kind of an ailment. And I mean, I absolutely avoid going to the doctors unless it's like an emergency, because a lot of medical trauma I went through as a kid to correct my, quote unquote, correct my disability. So even now I have to think and rethink 100 times before I go to the doctor, and which doctor I should choose, who will be more kind and understanding. So even like the most basic like kindness is not usually there in doctors, I feel, at least in my experience in the medical services that are provided in the government and government hospitals here in Delhi. Often they treat you like you are less than human, and they treat you like you're broken body parts, like your body parts are, you're just like parts which are broken. And so I have a lot of dysphoria as well. So because of the, which means that there is a lot of shame that I carry because of the medical model of disability which is how the government in India functions. They describe it through the medical model. Most of the policies that we get is through the medical model. And one of the biggest reason it's that the problems from because since it is the disability is seen through the medical model, is that people don't believe, like these professionals, they don't believe people with disabilities. And, historically, our feelings, our thoughts, and issues that we face are constantly ignored because we are often the first marginalized group seen as disposable. And that is the biggest problem, um, people like even for us to the way that things function in India is that they have these disability certificates in which they describe the percentage of disability, and according to the percentage that you have, you only then you can avail certain services by the government. So there are so many issues with the healthcare services, and even just seeing disability as a healthcare, as the medical model, which is like basically seeing it as something which needs to be fixed, which needs to be corrected, which needs to be, which is basically just parts of bodies or parts of mind which are the problem, or things like that, it really affects the body, and it affects the general access that we have, the say that we have in our own wellness and healthcare. Yeah, that's what I would say.
Yeah, and I will pick out a thing that a couple of both you and Hector sort of brought up, which is the way that society often will view disabled people as disposable. Because I think one place where that has, I think, really become visible is in the recent COVID-19 pandemic. And we have seen that the pandemic has had a devastating impact on communities that were already vulnerable and underserved. And many people outside of these communities have described COVID as exposing underlying systemic issues, but I think most of us in these communities have really been aware that these issues have been around for much longer. And it's really the rest of systems and the rest of systems out there that are really catching up to that. So I think, so next question that sort of builds on that is, how have current systems failed people in and communities of color during the COVID-19 response? I will turn it back to Hector again. I will keep on going around.
Thank you. So I really appreciate that, and the pandemic is not over. Yesterday, my family celebrated, well, didn't celebrate it, but we noted the 1-year anniversary yesterday of the passing of one of my uncles, a disabled man who lived in El Paso, Texas. In my family, because we had a lot of individuals that worked doing essential work or frontline work, we had 14 people contract COVID, 4 of which died from COVID. All of them were people with disabilities, including my brother. And so I think as we live this trauma that our communities are currently facing, we see that our lives as people of color are still actually at threat. We have all over have systemic barriers, discontinuation of services, access to public transportation, food in some places, housing, safe medical services, that are contributing to our communities slowly. It almost feels like a genocide of people with disabilities, because we have seen that even before the pandemic, many activists, particularly Black, Indigenous people of color, queer people of color, were really sounding the alarms about the impact that it was about to fall on all of us, because we were already dealing with them. there really was much attention paid to that. And as a consequence, a lot of those voices are no longer there. They've moved on. We've lost significant, voices in the disability community that were doing very important work. We have lost resources. And then when the vaccines came, which some of us even helped to develop, some of us actually participated with some of the vaccine developers to ensure that we had disability representation in the trials and in the outreach. When the vaccines came out, as a horrible slap to the face, we saw the denial of early access to those disabled individuals and communities that were high risk to have access to those vaccines until months later, which I think is a travesty in itself. If we look at the fact that we have people still to this day that have chosen not to be vaccinated for a variety of reasons that contradict the burdens that our communities have faced. And so we had those particular issues to deal with. Then we had difficulty getting the vaccines when they were available. They were inaccessible to us, particularly those individuals in communities or countries where they are significantly marginalized or have less resources. Our tribal communities, as an example, across the United States, was significantly impacted, particularly our tribal communities that were not in urban areas or were in areas that were already significant health deserts. We saw the vaccine. This is not our first pandemic. We have the New American History Month, so I think I want to remind folks that for those of us here in this United States, this is not our first pandemic. It's one of others. Our communities are been trying to survive the trauma. We have survivors of past pandemics, and so for this was another one to deal with. So we just compounded, and we began to really, have a significant flare up and lack of resources. But at the same time, we saw, impoverished communities trying to get very creative, trying to do everything we could to ensure that we had access. But even to this day, we have, medical rationing happening across the country. We have a revamping of conservatorship and institutionalized that are about to really hit the waves all across the United States. And so even while we're trying to survive, we are constantly having to deal with legislative and misappropriation of funds that really target our communities. And it feels intentional. It really does. And it seems like there's both an ableist and a racist and a sexist and a colonial, enemies to it. You can see where it comes. You can see that oftentimes the people making decisions for us are not particularly people of color to begin with. It's usually, they tend to be non-BIPOC, cisgender men, or communities that don't really either are welcoming or have significant diversity. And, the lack of representation mattered during this pandemic. We weren't the ones making the decisions that impacted our safety. And it continues to this day.
Yeah, right.
I want to add amen to everything that was just said. I would just describe from my perspective that the healthcare industry and system still struggles with meeting people where they are, especially people of color. We've talked a little bit about if you are outside a major metropolitan area, there weren't a lot of vaccine programs that were mobile. If you're dealing with transportation issues, how are folks getting access to the vaccines? How are folks getting access to care? And even when you're in major metropolitan areas, there's still, in communities of color, there needs to be more acknowledgement of the history of harm and the existence of the mistrust that has existed from an historical perspective. It's when you're looking at pandemic response, time is of the essence. And especially when we look at the beginning of the COVID-19 pandemic, people of color were not necessarily prioritized. The relationships with communities of color and organizations led by BIPOC could have been improved. And as Hector referred to, we lost people, we lost leaders, we lost, family members. And we will never know if they would have been more intentional, or the system itself would have been more intentional in prioritizing the most impacted, prioritizing the most historically marginalized in the initial response, how that would have changed things. And then in general, I would just say, again, it is about making sure that healthcare entities really acknowledge what the history has been. I think we all talk about, communities of color really aren't getting the services, aren't getting the access that they need. But unless the institutions are actually acknowledging the history, it's harder to have the conversations. It's harder to build those relationships. It's harder to have the trust. So I would say, as we look forward, that is something I hope many healthcare providers and many healthcare institutions will be more intentional in trying to address.
And Shivangi.
Yeah, I completely agree with Hector and Ryan. Everything they said, both of them, I feel is extremely real, and really describes the trauma and the pain that we have faced, our communities have faced. Um, so many of the knowledge that so much of the knowledge from those who have passed away is lost, and something that we cannot revive. And we have seen in some ways a little more accessible world through, because of online consultations and online gatherings. Disabled, I think, before that, disabled people have always been advocating for that anyway, and we were ignored. And we were already living in a pandemic sort of a world. I think, like in India, most disabled youth are, like what I've seen is that they're not even allowed. We are not even allowed to even leave our homes. We are, often confined to our own rooms, and we don't have access to basic rights like accessible transports and toilets, and even independent caregivers who are not our family members. So the government here doesn't even have any proper training for caregivers or funding for caregivers. During the pandemic, our mobility was even more reduced, and as I said, we became more disposable, because who cares if a mad, sick, neurodivergent, old, and crippled person dies? For the government, it just means less burden, and often even for family members, it means it's less burden when someone who's mad or sick or neurodivergent, crippled dies. And in so many ways, this is like a repeat of the eugenics that happened. We're experiencing eugenics all over again, where it becomes all about the ableist belief, the survival of the fittest, and that's so ableist. And it's they make it as if that science works against people with disabilities, when these kinds of theories come about, like survival of the fittest. But what we need, I think, I feel, is that uh, there is so much lack of professionals who are disabled, or who are queer, or who are trans, who are who are indigenous, who are bringing in knowledge, who are, like I said earlier, the knowledge that we of survival of the most sickest and the most maddest bodies and minds. So I think, like, we need to work more parallelly, instead of uh, uh, still sticking to the the colonized, the cis white men, what they said, the beliefs, the theories that cis white men had. is what makes us as if we are burdens to this society.
Right. So for the next question, I do want to I want to disclaim in advance. I know that everyone here comes from a very different context, and we don't all necessarily have the same background in internet in sort of global health. So I do want to open the floor a bit and allow you to sort of to interpret this a bit as you want. But while we're continuing on the topic of the ongoing pandemic, but also many of the recent ones, and that include many that are still ongoing as well, HIV, malaria, what have you. The other thing that we've sort of seen driving some inequities have been sort of the role of the United States as an imperial power, the role that the United States has had in global vaccine distribution, in global economic disparities, in access to treatments, things like the global gag rule, and previewing some of the responses people may have here. I think but we also see this on the domestic side, where we've seen the way public health measures have been used to restrict people who are trying to enter the country, and inappropriately. So if anybody feels that they want to discuss either the COVID-19 and sort of the impact that the United States has had on these global health disparities, either related to COVID-19 or HIV or malaria, or domestic policies, how they impact impact international communities. I want to open the floor to that. Hector, if you have anything, you can definitely start, and then we can go around. But feel free to add whatever you want to that question. So
thank you. So the work that I do with the National Disability Rights Network allows me the opportunity to work with all of the protection and advocacy agency in all of our 50 states and territories. And this is a topic that is a constant conversation for all of us. The United States has had great advancements in civil rights through hard, painful, bloody work. And with that also has come the disability rights movement, which I am so humbled to be able to stand on the shoulders and follow on the work that so many others have done before me. And for example, I live in Los Angeles County that has the largest public mental health system in the world. And it has the largest number of people with disabilities trying to get services. And I think one of the things that has been a significant challenge has been the way in which systems oftentimes contribute to the stigma and the discrimination, and sometimes really the abuse of people with disabilities by promulgating wrong narratives of cures, of treatments, of forced treatments as being, for example, some of the only alternatives that people can have to get better. And I think oftentimes that's always an easy cop out for those who haven't been able to help people the way that they should have been helped. And I think that really highlights with a lot of our public service systems, and particularly with some of our communities that are trying to migrate, seek asylum into this country. The National Disability Rights Network was the organization that dealt with the previous administration when people with disabilities, when all people were being held in detention camps in very inhumane and human rights violation manners. And originally nobody could get in because it was closed and everything, but because there were people with disabilities there, we were able to use our access authority granted by government to go and investigate, and we're able to really open the doors. And I think that's one of the ways in which this country sometimes really can lead, the disability rights movement. But on the other side, it also creates and generates, the United States is the hometown for misinformation, the hometown for stigma, and everybody looks at us. They look at how our people are treated. They look at how we communicate. They look at our holidays. Thanksgiving is a national holiday in the United States and in other countries because it's looked as a great thing. I personally don't look at it as a holiday. It's probably like the biggest example of gaslighting. But you know, the whole world looks at the country in what it does. And when the United States, you know, or elements really, you know, propagate false narratives about cures and fail to recognize our humanities as people who are just as perfect as everybody else, but also as people that could be dangerous. The notion that we're dangerous as people with disabilities, that we're violent, that we are incapable of making decisions, you know, that we should be somehow perfect to some standard that nobody else is held up to, you know, really is probably one of the things that harms all of us across the world. When we travel, I am terrified of traveling because I know the perceptions and norms and their ideas of what disability is, or especially if you're a person of color, is so dangerous. You know, but it's something that we oftentimes have to confront, and something that nobody really kind of addresses. You know, that we have to transform the system into a restorative system where those who have hurt us and are hurting us acknowledge, you know, that they're doing that, acknowledge that they have failed us. And I think only then can we really begin to have conversations about how they can help us heal, because they themselves have a significant amount of healing to do before they should really be helping other people. And we see that when we try to get services, when we try to overgive for ourselves, we're troublemakers, we're unstable, we're silly. You know, I think that's perhaps one of the most, there's just so many things wrong sometimes with the amount of misinformation that gets exported out of this country. It's a national pastime. And I think, you know, while we were dealing with the COVID pandemic, nobody really dealt with the misinformation or the stigma pandemics that we still have.
I think from my perspective, and I want to be very transparent in that the WITH Foundation, our work focuses solely on domestically. So within the United States, as well as in my personal and professional life, really my knowledge base, my experience comes from a United States perspective. But I would say we can learn from our response to other pandemics, and we can learn from looking at the lessons that we know, especially as a community of color and people of color, in order to address any form of disparity. In looking in this question globally, I believe it is still essential, especially if you want to be effective, to look to the communities and see how you can support the community in achieving the solution that they want. And anything short of that, in my mind, is not effective, is less effective. So how can we as a country, how can we as people support communities in achieving the solutions that they want to see? So that would be the only thing I would add from my perspective.
I think I've already spoken a little bit about this and how at least in globally what I see often and what I hear is that there is so much lack of access, and the basic rights are not given to us, like infrastructure is not accessible. So how to get into medical buildings, hospitals, when there is no ramps, or when there's no physical infrastructure. And that is one of the biggest issues that we often face. And also just having basic access to a grocery store, like going to the grocery stores or going to other things. You know, these things add to the to the health of a person. And often, like what I've seen, like I was saying earlier, that um, science and medicine are often treated as fields that are, you know, subtracted from the social movements. Like the disability movement is often like seen as, you know, social movements are not seen as something which are related to science and medicine. And you will not hear a lot about like the disability history from South Asia, from Africa, from South America. You will not hear a lot about disability movements and history from these countries, because so many times that we are just stuck in the definitions, the terminologies, and the diagnostics of the disabilities, or the even like trying to describe, labeling the different kinds of bodies, like even the like in our language, what how do we label the different LGBTQ letters and all of these things. It becomes really complex when it comes to translating them. And it's the same, like I said, in disability. In like I'll give you an example that in India right now, the current government we have is extremely entrenched in religious and caste based hierarchy and hegemony. And so they have given us this word, the people with disabilities, this word which is it's divyang, and it literally translates as the divine body. So it's almost like they want to give us this respect, religious respect, that you have a divine part of body part. And this is the almost the charity model of disability, in which you see the disability as something that needs it's like a karma, or it comes from bad karma, or it's like bad the bad things that you did in your past, or that you inherited it, or something like that. So it's a very biased way of looking. And so that's why we sometimes our history is not even recorded and seen, even though there is a lot of work going on, there is a lot of people with disabilities who are surviving, and we are challenging the norms. One of the biggest barriers I feel, for to have access, is because of capitalism and colonizations that our countries have faced. And now we are facing so much privatization of medical services, vaccines, and treatments, which is the main problem. Why are vaccines privatized? Why are medical services privatized? Why are they so expensive? So we really need to be looking at like disability justice movement, which tells us, which really advocates for anti-capitalist work in medicine. Yeah. Hector, you're raising your hand.
Yeah, before we move on, if you had something to add.
Yeah, no, definitely. I think that really highlighted, for example, here in the United States, our Native and tribal communities, especially like the one that I'm at, disability is the Western concept of disability doesn't exist, and some of our communities actually reject it. I am Shirikawa Pashe, and in my family, as a child, a normal diagnosis would have diagnosed me earlier on. My family was aware of, but in my culture, because we had experiences with people with me, our culture has different perspectives. We are similar to sacred. We have a specific, very important roles in our community, in my family. And I think when my family was first forced to seek treatment, not only did they not get the help, but I think those norms had to be taken away from them in order for me to try to get any type of help. And that was part of the way that also my family got sick, telling them, those are wrong. You don't know what you're talking. We're doctors. This is actually what's wrong. And, that's what's part of the way sometimes that the Western model, a colonial model, hurts people of color, particularly from communities where those of us that have, and in my community, they're called gifts, exist in communities. And I think that's why in our Native communities, in some of our communities, we're not supposed to talk about our disabilities with other people, because, they fear of being taken away the fear of being punished or having our families, exist. So I remember as a child, my grandmother telling me, "Don't tell anybody, that you do this. Be careful. And you could do whatever you." I was one of those people that would spin around. I actually do a lot of stemming, and in my family, in my culture, people would see that they were so happy. When teachers saw that, she was terrified and disgusted that I was allowed to do that. And so I think those particular norms, also poison our communities and impede for us to have access to culturally appropriate, culturally relevant, culturally directed services. As Ryan was mentioning, during this pandemic, one of the things that has also been very apparent, particularly for communities of color, is that community-based services have been a lifesaver. They have been able to really pick up the deficiencies as much as they can from some of our already structured systems of care. And they were local community services, people like our neighbors that were doing the setting up food pantries, delivering making masks. We had people paying people's bills, community driving people to things. Those were community-based services that are driven by the folks in the community that know what we need because they see it and they themselves need it and are able to create it. But unfortunately, those are the type of services that are not funded. They're not evidence-based. They're not driven by clinicians. They're not approved by institutions because, I think oftentimes the system has really devalued the work that Black, Indigenous people of color do, and also what LGBTQ people do and disabled people do. As a two-spirit person, as a gay person, our community had to develop services to care for our communities that were dying of AIDS and HIV, when the system wasn't doing anything. CBOs were created by our folks in homes and garages and clubs, to try to keep us alive. So I think that has been a long, if not tradition, but way in which, marginalized people try to survive, especially during genocide or, as eugenic periods in time where, people try to survive, which is what we are right now.
And I think as a counterpoint to that, we've also seen the way that institutionally based services have been really dangerous for us during the pandemic. And that actually, Hector, thank you, because that leads into sort of our next question, which is the way that both systems of institutionalization, including mass incarceration, how they've impacted public health. And I think the pandemic the COVID-19 pandemic has provided many examples of this, but I know that it extends much beyond that. So if any of you care to comment on that,
This is Hector. First of all, I just want to say that prison is never a treatment, because and I think there's a lot of folks out there that are under this horrible, ignorant notion that sending people to jail is going to help them get better. And I, coming from Los Angeles County, where we have the largest number of people with disabilities in the country in two places, and I kid you not, in Los Angeles County, the largest number of people with disabilities can be found in one of two places: in our Twin Tower jails downtown, which I've personally been at, or out in the street homeless, where I've also been at. And I think that has always been kind of a treatment modality for people that don't know how to help people. If we can't help you, then then there's something really wrong with you. If I'm not able to help you, then there's something really wrong with you. And I think the thing is never the other way around. The mass incarceration of Black, Indigenous people of color, particularly Black, African American heritage and descendants of slaves, it is to this day an incredible travesty that even to this day we face. And here in Los Angeles County, one of our biggest efforts as a disabilities movement is to close down those jails and also try to close down our Department of Mental Health, which is a giant institution of harm for communities of colors. And it gets a lot of funding, and there's some really great people, but we do experience a lot of harm because of that.
I think I would add, first and foremost, I want to thank ASAN for being an organization that was intentional in tracking the number of COVID-19 cases by those who reside in congregated settings. In general, I think we all know those that are in congregated settings were among the most impacted by the pandemic. And as Hector was just alluding to, when we're talking about congregated settings, in large part, we are referring to communities of color, to BIPOC individuals. So I think it's important to never forget that and always say that out loud, because sometimes when we talk about large institutions, the actual people and the actual lives get lost. And it's important to know that, even within large settings, each individual life matters. It's important to, each individual life has lived experience, has value, has expertise. So we need to do what we can to make sure that we're addressing it, we're valuing those lives. And then in general, in terms of COVID response, it is inside institutional settings, the actual response was woefully lacking. I don't think there's any way around it. Far too many people died who were living in congregated settings. So I think in order for us to have a more effective public health system, we do need to be more intentional about acknowledging the fact that there are sometimes additional risks to residing in congregated settings. And how do we address those risks?
Yeah, so I think this is a really important question because so many, disabled and sick people are stuck in institutions, and we have no, so many of us are stuck in institution, and because of the prison industrial complex, it impacts the body mind on so many ways and levels. So much more mental disorders like depression and hallucination, anxiety, etc. is it is induced within these four walls that we are forced to be in. And also because of the constant fear, there is so much fear and so much uncertainty about what could happen or what you're going through, especially in these kinds of institutions where you really have no control over what kind of uh, 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 what even your basic day would look like. So I feel like in general also, like the immunity of the physical body reduces when one is faced with these constant ignorance and fear and harassment in institutions where you are not heard, where you are not acknowledged, where it's just your livelihood depends on people who are your abusers. Um, so I think also I feel like like I said, like the biggest issue is privatization of these institutions, and how it reduces the accountability and ways in which you can redress problems that you're facing in these institutions. So it definitely impacts the public health because I feel like a lot of experimentation also often happens with those who are institutionalized, and those of us who yeah, there's so much experimentation, like with marginalized bodies, like a lot of the vaccines were tried on for the first trial was done on a lot of marginalized bodies, at least the ones that are problematic. Like there is one of the vaccines that were available here in India called um, the Covaxin, and it was developed in India, and it has a really problematic history of being tried on these the untouchable and Dalit communities, which are lower caste basically, in the hierarchy of caste that is often followed in India. And that it was really problematic because you cannot just do trials on people, and it just it speaks more about like disposability again. And also there is so much impunity that a lot of these cis het and upper class people who work in these privatized medical institutions, medical and prison institutions work in, there is so much impunity that they have, as we hear even in the US. There is the police who, if they can get away with so much violence that they cause, they can just get away with all of these things. That is the impunity is just shocking, and it's not just the police, it's people with so much money and privilege. They are not the ones who are ever facing any consequences of. They are the ones who are doing most of the the so-called crimes, as they say. And so it's really important, I think, to abolish these systems, and trying to really shift towards a more transformative justice point of view, in which it talks about how we need to really look at justice in a way where you can redress where you can get justice for the victims by really seeing the victim as the expert, the person who faced who was the victim of a crime, seeing them as the expert instead of these lawyers and the so-called judges who and even looking the transformative justice, I think, is one of the biggest ways in which we can really dismantle this system of incarceration.
Yeah, and I do want to, I know I'm not a panelist, but I do want to just build on that to emphasize that we have seen similar prison abuses occur in the United States, that not only have many states made prison populations a very low vaccine priority, but we've also seen examples of prison experimentation that were sort of done ad hoc during the pandemic. So Hector, if you have something to say, you can definitely join in.
Yes, so our communities of color, disabled communities, oftentimes communities that are marginalized, particularly in the United States, we have a long, horrible history of abuse and experimentation. And I'm aware of stories and cases all throughout the world. Of this. Our organization, myself, partner with the Global Health Initiative, COVAX Initiative, at the beginning to try to develop, alternatives or treatments that were going to be free and available to everybody. And I think once a lot of people realized that there was a significant monetary value for this, a lot of the safety rails that countries are supposed to have in place to prevent, the continuing of this abuse really disappeared. And so that this is definitely an issue, human rights issue, that needs to be elevated, given the fact also that while our communities were used to develop these things, most of our communities around the world don't have access to any type of vaccine or treatment options, and might not have those options for years to come, despite the fact that wealthy nations like the United States is throwing away vaccines because people don't show up for appointments, people don't want them, people are scared, or they get in. I mean, our vaccines sometimes just get thrown away because nobody shows up for them, and it is completely gross to know that happens while we have communities around the world, that are struggling to stay alive. They're migrating to try to get safety for them and their children. Congregate settings in the United States really have been execution centers for our communities, particular community of colors. Here in California, United States, here in California, our state hospitals where individuals are forced to reside for a variety of reasons, we had outbreaks. We had people in state hospital that died. We had a lot of people in our prisons and jails, become infected, not because they were out there not wearing a mask, but because there were a lot of individuals that were coming in, visiting, and working, who exposed those individuals. There were individuals that succumbed and died, and they were only there waiting to get processed. We had somebody that was in jail for a jaywalking ticket that he couldn't pay. He was so poor, and he was put on hold in prison, and during that time he contracted and died. And so I think we have really a need to uplift and really honor those individuals that have been executed or killed or died or neglected, but also to hold accountable the systems, because those systems are still in place. We know that money is going into jails and detention centers continuously, even with this administration. We know that sheriff's budgets, despite all the social justice work that was done and is being done across the United States, instead of going down, they went up. They're going up. Our sheriff budget here in Los Angeles County is like 3 times the budget of the Department of Mental Health. And for some reason, the sheriffs are the ones that have, the majority of interactions with people with disabilities. And so we know that there's a significant lack of organizations that sometimes really guide the money and take those services away from our people and our communities. And when they do that, not only do they take away the services from people, but they impact our communities for generations to come. They destroy our communities. Many of us live not only in food deserts and technology deserts or services deserts. We live in human rights deserts, where our children, our families, wake up one day and some of us are gone because we've been put in jail and we don't come back, and there's nobody there to take care of them. There's nobody there to take care of communities, and that has long-term impact. And we see it. We see the health disparities, in our communities of color, in our urban settings, in our rural communities. It's a long-lasting impact, and there's no investment in fixing those or re-healing those patients once we have been removed. And that's something that is really missing. And again, that's why a transformative approach that is perhaps, restorative is needed, because you can't get help in places of harm. And the same thing happens for our communities.
Okay, well, again, that is a wonderful transition to our final question. And I'm acutely aware of the time, so I do want to lightning round this a little bit, but I think the next question just follows from that. So what are the next steps here? What can we do to reduce the harms that systems are, reduce harm against disabled people of color? What systemic changes can we need to happen to make those changes?
I'll go ahead and go. From my perspective, I have 4 things. The first is, as we've all spoken of earlier in this session, there does need to be an acknowledgement of the history of harm in order for us to move forward, in order for many of the things that we will discuss as working towards effective responses and effective solutions. It is important to acknowledge that history. Secondly, I think it's important for us to look not only towards embracing culturally competent approaches, but also approaches that have cultural humility. And when I say cultural humility, it's a framework that examines the imbalances that can exist between partnerships. And I think when we're looking at how we can develop more effective healthcare systems, it's important that the systems are not only culturally competent, but they also embrace a cultural humility approach in providing that care. Thirdly, I'd like to say we need to be intentional in acknowledging and uplifting the lived experience of people with disabilities, point blank, period. It's the lived experience of people with disabilities is not nearly valued enough by much of our healthcare system. So we need to be intentional in respecting and valuing the lived experience that all individuals with disabilities have, all disabled people have, especially disabled people of color. The more impacted, the more historically marginalized you are, the more that perspective, that experience is valuable. And lastly, I would just say, as a funder, and WITH is trying to be part of the solution, but I think it's critical for funders to be more intentional in providing funding opportunities for BIPOC-led organizations and partnership with BIPOC-led organizations that are operating in the healthcare space. So that is what I would add, those 4 things.
I think I agree with Ryan a lot, and coincidentally, I also wrote 4 points for this question. So for me, I think one of the biggest things that needs to be addressed is collective access, which means that you're not only addressing, like when you think of accessibility, you're not only addressing infrastructural access, but also looking at access for marginalized gender, race, caste, sexuality, etc. So, for example, it is no use if you are trying to make a ramp in a big hospital if you haven't addressed the affordability of services in that hospital, because a ramp will not really help access for a person who is poor and a wheelchair user. Or if you haven't addressed the gender binary, where you assign genders to people to be able to address their medical needs, so you will not be able to address. So then your hospital is not accessible to a trans and wheelchair user, even though you have a ramp. So that is what collective access means to me, and that really involves taking an intersectional approach. And it means challenging transphobia, racism, ableism, and what Ryan said, like really questioning the laws and policies around economic and housing rights, because that also contributes to overall wellness. And for me personally, I would rather work with, herbalists, shamans, witches, and traditional healers of colors. All this ancestral knowledge often, gets lost in colonization and neo-colonization. So what I've seen, like I've tried to do a lot of research in this area, where in countries like China and Taiwan, often you have the option to choose from either allopathic medicine and Chinese medicine, in the like right next to each other. So there, when you're going to the hospital, you have the option of choosing the Chinese medicine or the allopathic medicine, which is the biomedical medicine that is available in hospitals. And even in India, like we have a lot of hospitals where we can choose from between like homeopathic, Ayurvedic, and naturopathic doctors. So even and so yeah, I think those are the things that are having the right to choose, and having different options for people is really important, and really trying to preserve that ancestral knowledge is also really important. Um, and the third thing I wanted to say is that in my work as a in my work with the determined art movement, we are trying to do a lot of anti-capitalist work by collectivizing in like artistic ways. So really encouraging community-based healing practices like art and movement therapies, spiritual healing like Reiki, and peer-to-peer support groups, and yeah, things like that. And I also love like there is this activist, their name is Mia Mingus, and they have this theory of pods, where you have an immediate group of people that you call pods. so you can contact them when there is a need for like emergency and things like that, instead of approaching a professional or someone professional. When I say professional, I mean like people who are quote unquote qualified by the institutions, the educational institutions, because of the medical degrees or the or because they have the yeah. So I think you get what I mean. And then the last thing I guess I would it's a more brief point, is like biggest thing I think that will really help reduce harm against disabled people of color is collective rest, and really resting for resistance. So that would be my last point.
This is Hector. I think my first one, vote. Register to vote. Vote. Exercise your right to vote. Make your presence known. Make your vote be counted. Make yourself be counted as a member of the society. Assert. Take up as much space as you need to be yourself in this world. Do what you need to do to take care of yourself, your family, and this community during this pandemic. I think my other views are really kind of based on my community's long-standing, survival through pandemics. The COVID, we had HIV, we had polio. It just keeps going. And I think some of the same things that we've seen back then, we're seeing already again. The winding down. All of the disability laws that we had, at least here in the United States, did not help us one bit. The ADA, the Olmstead, none of those things were enforced. Nobody was really there as much as they should have been there to enforce those laws, from the federal government to state governments. I think there really needs to be an enforcement mechanism to ensure that the rights of people with disabilities in the United States and across the world are being recognized, that we are being recognized as equal human beings worth of value and dignity, to live and make mistakes like everybody else, because we haven't really gotten there. Progress takes time. We have accomplished so much. We're still doing it. We're surviving. We're trying to survive. And I know change takes a long time. And it's so hard to think of that and accept that when you're struggling to survive day by day, minute by minute. And that is the main reason why I think it's important to have authentic stakeholder presence, in boards and commissions, and in positions of power, in positions of awareness. I'm so thankful for all the work that ASAN is doing and has been doing during this pandemic. The lack of data around people with disabilities was completely unacceptable. We became invisible as we were dying. Nobody was collecting, and still to this day, there's not a lot of data, disability data, on how COVID has impacted. We don't really know how many of us have died because the recording mechanism sometimes didn't even bother to include the fact that we were in congregate settings, that we had been exposed to COVID. They just looked at some other medical conditions and wrote us off, and I think, there's a significant amount of accountability that needs to take place during this pandemic, because we had a lot of mechanisms, we had a lot of, preparation for things like this, and we're not expecting it, but everything that we had really, for the most part, was dismissed. We had our folks struggling to get food. We had people that were eating cat food because they couldn't go for food. We had people that died at home alone because they couldn't get services. And I think that really has to be one of the, reminding lessons of what happens when people are left behind, because that's basically what we were we were left behind. We were deemed not worthy of being part of society. And I think fighting for that every day is my last point. Thank you.
Thank you. I know we have a few minutes left, so I just want to read out some of the comments that came in. I see a couple of really good really insightful comments from Dax in the chat here. So one is regarding trans folks and the impact that the pandemic had on services and medical care that are genuinely life-saving, but were quote unquote non-essential, but were essential for the people who needed them. Things that included gender affirming and transition care, and without which people, it did actually endanger people's lives. And so I think that is a really important point about one of the things that I don't know that we touched on, which is the way the stress on the system created by COVID-19 also stressed a lot of services and a lot of healthcare that we relied on. And that itself was another impact that COVID-19, the pandemic had on those systems, on us through those systemic issues. And then the other comment was on an issue that we did touch on, which is the United States and the extent to which we were providing vaccines abroad, which was much more limited. I think there's been a lot of criticism regarding how the extent to which the United States was distributing vaccines globally. And there very much was the sense that the US could be doing more, and that the vaccines we had in the US weren't even really being used, and often had to be, and in many cases did have to be thrown out because people refused, or the distribution was mismanaged. We do know that there are still many people in the US that can't get access, but at the same time, many of our vaccines were going to waste while we were still not distributing them. So I do want to just acknowledge those comments, because I think those were really important points as well. Thank you everybody for joining us today. Thank you so much to the panelists. This has been a really amazing discussion, and I'm grateful to have been a part of this. And I think we can turn it over. Thank you.
Thanks everybody for joining us. We'll be continuing our gala program with the continuation of the film screening. This Is Not About Me at 5 p.m. Thank you everyone. Have a great day.